Orringer, good morning.
Hi, Joe.
Thank you very much for your interview with us at the American Association of Thoracic Surgery Conference here in Toronto. In this series of the Giants of Thoracic Surgery, we would like to discuss with you the procedure which you helped pioneer, the transhiatal esophagectomy for resection of the esophagus. Specifically, we'd like to review with you some of the key steps to making this a successful operation and discuss in a similar way the way you might walk through the procedure with some of your residents. I'd like to start with a question on perhaps a preoperative workup and wonder, in this era of more and more diagnostic testing, do you think a PET-CT and an endoscopic ultrasound are absolute requirements or optional for a preoperative workup?
In the evaluation of patients with esophageal carcinoma, the CAT scan followed by the PET scan followed by endoscopic ultrasonography have become state-of-the-art at the present time, and that is typically our standard. Now, if a patient has a CAT scan that shows stage 4 disease, the need for us to pursue any further workup before forwarding the patient to the oncologist obviously doesn't exist, but in the typical surgical patient, all three of those studies are routine now.
How about specific measures prior to surgery? You're interviewing a patient today, and you find out he's teed up for surgery, but he's actively smoking. Would it stop you from the operation? And if it does stop you, how long do you think you're safe to delay, given, of course, the concern over the cancer progression?
Well, Dr. Luketich, that could be the subject of the entire interview this morning, because I believe in my mind that with all the surgical advances that you've developed, that I've developed, probably the key factor responsible for our decrease in operative mortality and morbidity has to do with how we prepare our patients for the operation. We have an absolute mandate that we follow that patients must abstain from cigarette smoking for a minimum of 3 weeks before surgery. Now, because the majority of our patients with stage 2 and 3 esophageal cancer have neoadjuvant chemotherapy and radiation therapy, there's a time lag before the operation anyway, and this presents no hardship. But I'm fairly unyielding with that. I think that majority of our patients who come to us with esophageal cancer have had their tumors for 12 to 18 months before they ever see us, and so to add a few weeks at the other end so that they have a more successful surgical outcome is well worth the investment. And the smoking is one issue. The other issue has to do with ambulation. We have our patients walking 2 to 3 miles every day. I'm easily able to tell them to do that because it's what I do, and I tell them I expect you to do what I do. And we get them walking so to condition themselves for early ambulation after surgery, because they're told that they're not going to the intensive care post-operatively, and they'll be expected to be up and walking the next day. And if the expectation is set, inevitably patients do it. So the walking, the abstinence from smoking, and then we issue patients an incentive inspirometer, which typically is handed out after operations all throughout the country and the world after surgery, where the poor patient with an incision is given their little plastic toy and told to inhale and to deep breathe, and they look back at you and just wonder, what on earth are they asking me to do with all this incisional pain that I have? But patients who have been conditioned to do this and to take 10 deep breaths 3 times a day before they come into the hospital already have a respiratory program underway, and they get annoyed at themselves when the first few breaths after surgery aren't as good as what they were doing beforehand.
Now, you're in the operating room. Your patient's ready. He stopped smoking. He's asleep. Do all patients get an endoscopy by you on the table, firstly? And prior to your midline laparotomy, do you think it's advisable for that small percent that are missed by PET, CT, and CT to start with a laparoscopy prior to, even though you may be intending to open if it's a go? So the two questions: EGD, your own endoscopy on the table, and would you consider laparoscopic staging prior to a midline laparotomy?
I think it's been a principle of good thoracic surgery, going back to Dr. Alexander, that if you're going to operate on a thoracic organ, you look at the inside first. And we would never do a pulmonary resection without looking down the airway at the time of surgery to be sure there are no surprises. And similarly, we would not take out the esophagus without looking down first. There are enough patients with skip lesions, with abnormal esophagus proximal to the area of the tumor that we want to be certain that there is an adequate proximal esophagus to which we can anastomose the stomach. So yes, it's a mandate. We always do endoscopy. Regarding the issue of laparoscopy, I know that there must be a small number of patients who have disease where it's an open and close, and a whole day of scheduled operating time is essentially flushed. They're few and far between. I'll bet this doesn't happen twice a year in our practice. I think that patients now are so completely worked up with imaging studies that for practical purposes, doing laparoscopy adds time that we're trying to minimize for the operation. It may have value, of course, in tumors of the GE junction where there's some angst about gastric involvement, but I'm not even sure until you lay hands on the stomach that you know exactly where you can divide it safely.
Okay. Now, let's get into the operation. Lymph node dissection or lymph node sampling, and if there is a dissection or sampling, is there a minimum number of nodes that you have, a minimum number of stations that you sample? Tell me how you handle that lymph node approach.
Well, obviously for our operation, we begin in the abdomen, and I feel that the lymph nodes along the high lesser curvature of the stomach, the celiac axis, still remain the most important for staging and for clearing disease. So that from the abdominal side, with our approach, once we have freed the greater curvature of the stomach and then start on the lesser curvature of the stomach, we'll carry our dissection down to the origin of the left gastric artery from the celiac and sweep all lymphoid tissue and fatty tissue from the vessel laterally with the upper stomach. And we continue that clearing process up through the hiatus and get the lower paraesophageal lymph nodes as part of the dissection as well. Obviously, with transhiatal resections, the lymph node dissection ends there. We have sampled enlarged subcarinal lymph nodes seen on CT scan through the hiatus, particularly in thin people. But the bulk of our clearing is the lower half to third of the esophagus, the paraesophageal area, and the upper abdominal nodes. And we don't count lymph nodes during the operation. Typically, the patients will have between 10 and 15 lymph nodes when our pathologists assess the specimen.
Now, regarding mobilization, obviously some stomachs are much more mobile than others, and one thing I've noted in my own practice, it really wasn't taught or stated in a textbook anywhere, is that if you've had prior gallbladder surgery or prior dissection in that area, you can be really stuck and you might be up for another half an hour of mobilization. But one, I'd like to know your comments about prior gallbladder surgery, if you think that's an important point for the residents. And two, do you think it's always necessary to even do a mobilization? If you pick that stomach up and the pylorus lies freely, tension-free, on the right cruise, are we done?
Well, the historical development of transhiatal esophagectomy had to do with me coming back from England in the time I spent with Belzy, literally traumatized as a resident because I had 5 patients with leaking intrathoracic anastomoses in the intensive care unit dying of median stenitis, and thinking those few scattered reports that I had seen from Asia where the stomach had reached to the neck every now and then, did that just apply to the Asian population, or was it true, as I had been taught, that the North American Caucasian stomach reaches to the apex of the chest, and that's about it, and not much further comfortably. And that led to me coming back to Hopkins as a resident and spending a lot of time in the autopsy room mobilizing stomachs, seeing why that stomach, which normally has its curve to the right side because of how it's tethered by the left gastric vessels, can be straightened by progressive division of the along the lesser curvature as you sweep the branches of the left gastric away, and then a generous Coker maneuver to allow that pylorus and the pyloroduodenal junction to be moved from the right upper quadrant to the midline. And so it became a part of tension-free, maximum gastric mobilization to bring the stomach to the neck, to incorporate a generous Coker maneuver into the operation. So for me, that's part and parcel of the abdominal phase of the operation. I couldn't imagine the operation that I do without mobilization of the pyloroduodenal junction. And your statement about prior surgery is obviously one made by an experienced esophageal surgeon. A prior laparotomy and the way the greater omentum likes to flip up to the abdominal incision, I always tell my residents that in the process of bringing down that omentum, you may go right through the right gastric epiploic, which is pulled upward against the abdominal wall, and you'll end the operation very quickly as you destroy your gastric conduit in that process. So prior surgery is a big deal for us, and we approach it very cautiously. And yes, it does add time taking it down from the gallbladder bed, but we do it. We just did it, just as you described, a very meticulous small right angle and bovie dissection to get the duodenum, which had just adhered to the gallbladder bed beneath the liver.
Thank you. All right, a typical GE junction tumor, gastric tube or whole stomach?
You need to have a gastric margin, but we have found that 4 to 5 to 6 centimeters of stomach distal to tumor is adequate margin. It was one of the things that we were concerned about. I had been taught that if you had a GE junction tumor, you need to do a hemigastrectomy to get adequate margin of resection. To do a gastric pull-up procedure, you need to retain the apex of the greater curvature of the stomach to get that to reach to the neck. And as you know, dividing the stomach in a fashion that allows you to be beyond tumor, but to have an acceptable margin is the goal of the operation. So those are the patients that if I'm concerned about the extent of, when I see, knowing these numbers, that 40 centimeters is the GE junction in the vast majority of human beings, and if we get endoscopy reports that say that the tumor is from 37 to 42 to 43, when the tumor starts going down beyond the 40 centimeter mark, you're into the stomach. And that means you have to have a plan B. So that's when we prepare the colon, and we have a backup plan in the event that a major gastric resection is needed. But Jim, from we don't subscribe to the principle of tubularizing the stomach. It is almost as though when we finish mobilizing the esophagus in the transhiatal approach, one of the steps of the operation is for the surgeon to put his whole arm and forearm up through the hiatus until the fingers are up in the cervical portion of the wound to establish the tunnel and to be sure in the mediastinum and to be sure that there are no undivided vagal branches, fibrous branches that will stop the stomach from coming up. Now, that's not needed in the minimally invasive approach, but we feel that in bringing up the stomach and ensuring a tension-free delivery, there's got to be a good tunnel. We have never tubularized the stomach because, from my way of thinking, there is no other organ in the abdominal cavity that has the blood supply of the stomach, the 4 vessels that supply the stomach as an esophageal substitute. There's no better organ with which to replace the esophagus. And that stomach lives after division of the left gastric and the left gastroepiploic vessels because of that extensive submucosal collateral circulation. In my mind, if you tubularize the stomach and have a long gastric suture line along the right side of that stomach, you have disrupted submucosal vascular strength of that stomach until it gets over the shock of the initial mobilization. Then, of course, the vasculature is fine. So I have tried to maximize the remaining stomach so that there is the best blood supply to that end of the stomach as we can have. So in my thinking, the more stomach we have, the better the blood supply will be, and the more narrow we make the tube, the more we're disrupting important submucosal collateral circulation. There's probably an in-between that's the right answer, but we try to preserve maximum stomach consistent with a cancer operation. We'll check the gastric margins with frozen section for GE junction tumors to be sure that we have an adequate margin, and they'll check the entire margin for us to ensure that we're not leaving tumor at the margin. And in our series, when we looked at 1,400 distal esophagogastric junction tumors, there have been 2% that have had a final pathology report that said that there was microscopic tumor at the gastric margin of resection. So for 98%, saving stomach works by going 4 to 6 centimeters distal to tumor.
In the era of more and more GE junction tumors and less mid-esophageal tumors, and you may have already answered that for us just now, but you think you're seeing more patients that you might consider an Ivor Lewis because you don't have the length? Or would you prefer to just go ahead and take out the stomach and use the colon and take it to the neck?
My preferred approach is always to use the stomach. I think that to have a patient leave the operating room with an anastomosis in the neck has to be different than leaving the operation with an anastomosis in the neck and 2 in the abdomen, and the technical complexity of colon interposition, which I love to do, but which is nice to avoid in the majority of patients. And so still the majority of our patients wind up with esophageal replacement using the stomach brought up to the neck. But again, for those where we are afraid that the stomach may be involved for a considerable portion, we have a plan B and have the colon prepped and ready to go.
Regarding the controversy over drainage procedure or not, do you think everyone needs a pyloroplasty or myotomy? And do you think if you're doing one or the other, there's a significant advantage of one over the other?
Well, like all thoracic surgeons, I have a definite opinion. And the definite opinion here is that the experiment's already been written. We know that with patients undergoing vagotomy for ulcer disease dating back a long, long time ago, that 15 to 20% of those patients wouldn't empty their stomachs. And that's why the V of, or the P rather, of vagotomy and pyloroplasty, the V and P came unto being. The first ulcer operation being a vagotomy, and then people figuring out that that was insufficient because of the number of people who wouldn't empty their stomachs. And so we can take one approach that says 80 to 85% of patients will have no problem with gastric emptying if their vagus nerves are divided. So therefore, we'll deal with it if we have to. Going back to that pylorus operatively can be a tour de force because of the overlying liver and the concern about disrupting the blood supply, the right gastroepithelial vessel if you have to go back in, although you certainly can. And doing a balloon dilation of the pylorus afterwards, I'm not sure that I can convince myself that that's better. I think that an obstructed gastric outlet is such a catastrophe after esophagectomy in terms of aspiration, blowing the anastomosis. I'm not willing to take the chance. And so, yes, I think it's a mandate. Yes, I do a gastric drainage procedure on every one of these patients. And my preference is a pyloromyotomy. It has been since I first did the operation. I like to leave the operating room with nothing in the abdomen that I have to worry about. So I don't have a suture line, and particularly when I'm bringing the stomach up to the neck, having a gastric suture line, a pyloroplasty suture line at right angles to the stomach where you're pulling the stomach up, it worries me because it does hamper somewhat your upward reach of the stomach, or it potentially can. So I prefer a myotomy, and I'm always struck by my colleagues who say that, well, if I get into it, I convert to a pyloroplasty. There's no more need to convert a pyloromyotomy to a pyloroplasty because you've entered it than there is to do an esophagectomy if you get into the esophageal mucosa doing a esophagomyotomy. A few 5/6 proline sutures if you get into it, and putting a patch of omentum over that will protect the mucosa fine, and people do well, and that happens less than 4% of our patients, but it does happen, and you just have to deal with it. But I always do a drainage procedure, and my preference is a pylori myotomy.
Well, I couldn't agree more with the drainage procedure. Music to my ears to just be here talking to you about these things. Feeding tube. All patients get it. Some patients only nutritionally compromised, only those with neoadjuvant, or do you just do it in everybody?
We do it in everybody, and I think about it all the time because everybody doesn't need it. But 1%, when we look back, 1% of our patients in long-term follow-up had a problem with their jejunostomy, either obstruction at the J-tube site or a late loop of bile around the J-tube site, 1%. If we look at the other side of the story, particularly in patients who had neoadjuvant therapy, who are anorectic, who are adjusting to new eating habits, having that tube in to help them over that initial hurdle after surgery has been a real bonus. So yes, I continue to put it in, and I think it's an important part of the operation.
Very
it's a
good.
safety factor.
Another important point that I couldn't agree more with. Regarding the next step of the operation, you're ready to move forward. You like the look of your gastric tube. We already understand that. I think if you don't, you're going to consider colon if there was a technical problem or there was a problem with the blood supply, which should be exceedingly rare. What about the concept that some people are pushing of preconditioning the stomach? Obviously, it's not part of your routine. Do you think that it should be?
I think that the concept of preconditioning the stomach allows people to write a lot of papers for the literature, and I think it's an excuse for poor surgery. For people who say that we have anastomotic leaks because of the poor blood supply of the esophagus, because of the poor blood supply of the mobilized stomach, it's an excuse. And the reality is that if you critically look at these operations, and for you and I and for people with large series of these, we're doing it every single day virtually. The rule that has dominated my operating room now in recent years has been pink in the belly, pink in the neck. If that stomach hasn't been traumatized in the process of mobilizing it, of getting it away from the spleen, of tying short gastric vessels too tight, too close to the stomach, of handling the stomach in a way that makes that tip of the stomach purple instead of pink, there'll be a leak. And you can precondition away, and that's not going to solve anything. So the real issue about avoiding an anastomotic leak is not preconditioning the stomach so that the blood supply is adequate. The blood supply is adequate. It's how we put things together. So there's no question in my mind that you can augment blood flow to the upper stomach by dividing the left gastric artery. I just don't think that it's necessary. I used to think that if a patient has had one or two or more fundoplications, for example, that there's no way that we could use the fundus after rewrapping it to bring up to the neck because the stomach wouldn't be healthy. Well, my experience has been that it's almost like a delayed flap. The stomach has been devascularized in the process, relatively devascularized in the process of doing the fundoplication, but it's had an opportunity to develop submucosal collateral circulation so that when it's unwrapped, you actually have a stomach that has a good circulation that you have to work extra hard to kill. And I think that you can still use a stomach to bring it up. So the long and the short is, I think you can precondition in the laboratory, and it probably would work in humans as well. It's just not necessary.
Now we're ready to go to the neck. So your abdomen's open, your stomach, you're happy, everything's good, you're moving along, and you're taking your resident through the case in the neck. How do you approach the neck?
Well, I was going to do this with hand motions, but I think this is the time where I'm going to bring in some visual aids here, because I think this is an important part of the operation. So the patient, as you know, is positioned with a folded blanket under the scapulae and the head turned to the right and positioned on a head ring so that we have access to the left side of the neck. Now, the most important anatomic landmark is the cricoid cartilage. So when I'm walking a resident through this, I will tell them to show me the thyroid cartilage and drop down and to feel the cricoid cartilage, because that's the beginning of the cricopharyngeal sphincter, which is the start of the esophagus. So the traditional carotid incision from the angle of the mandible down to the sternum has nothing to do with this. The esophagus begins at the cricoid cartilage, and our incision, therefore, is 5 or 6 centimeters from the cricoid cartilage down to the sternal notch, and anything above that has nothing to do with the esophagus. There is no esophagus there. That's pharynx, and it's wasted incision. So that's the important landmark, and that's the upper end of our incision, the cricoid cartilage. And then the incision parallels, that dotted line that you see in the diagram, parallels the anterior border of the sternocleidomastoid muscle. Now, the steps of the cervical mobilization are absolutely reproducible, and we do it repetitiously. So the incision is made through skin, platysma, and goes down to the anterior border of the sternomastoid muscle. Once we see the sternomastoid muscle and we have that anterior edge of the muscle, the index fingers can be put into the wound and spread so that you have a long edge of sternocleidomastoid muscle visible. As you spread the sternomastoid muscle, you see the fascia behind it, and that leads you directly down to the omohyoid muscle, which is the only structure running in that direction in the neck. A right angle clamp placed under the omohyoid muscle allows division of that tendon, which, if you grab, is contiguous with the omohyoid fascial sheath that runs in both directions. There's fascia attached to the omohyoid muscle. So that's incised in both directions. Once that's done, the fingers again go into the wound and spread, and the omohyoid fascial layer takes you down to the carotid sheath. That's how you get to the carotid sheath. And once you have spread those fascial tissues, you will see a middle thyroid vein, typically, which we divide between clamps and ligate. And then immediately opposite the cricoid cartilage again, and it's, I tell my residents that it's just like going home to grandma's house. Immediately opposite the cricoid cartilage is the inferior thyroid artery. Once you have separated the carotid sheath from the fascial tissues in which it lays and retracted it toward the patient's laterally, then medially you'll see the inferior thyroid artery. And we divide the inferior thyroid artery between fine right angle clamps and ligate it. And once that's divided, you can spread your fingers apart right along the prevertebral fascia, and that will take you down into that plane along the prevertebral fascia that we're all accustomed to using when we drain an esophageal perforation, for example. And you see in these diagrams a lot of fingers, and there are a lot of fingers because we don't put metal into the wound against the tracheoesophageal groove. Metal never goes there. So this shows the divided inferior thyroid artery. And once that's divided, the assistant's finger, the assistant who's standing at the head of the table of the patient's right or left, will put a finger in the tracheoesophageal groove, not deeply, but just against the trachea, and elevate toward the patient's head the esophagus and trachea, which draws esophageal length into the wound. Now, the position of the recurrent laryngeal nerve which appears in these drawings as a nice white line, is known. We never see that nerve if we can avoid it. We stay posterolateral to it, and once we have the esophagus and trachea brought up, we begin a sharp dissection, hugging the wall of the anterior esophagus and spreading until we can get behind the trachea. And then the finger goes around the esophagus from the front, never any metal contact against the nerve. And with the finger around the esophagus, a Penrose drain is passed against the finger, again, never any metal against that nerve, and is brought around, and you've encircled the cervical esophagus. Now that operation can take 7 minutes, or it can take 70 minutes, but if it's rehearsed and gone over, the steps are absolutely reproducible. It's a stepwise procedure that allows you to encircle that cervical esophagus and start the dissection, always staying away from the tracheoesophageal groove in that nerve.
We're moving on now, and your tube's ready, your neck's relatively ready, you're around the esophagus. Tell me, how do you connect those dots? You've got one hand in from the abdomen, you've got a finger in from the neck, and let's say it's maybe early in your experience, and you can't touch your finger. This is you're out on your own now. You're not with Dr. Orringer. What do you do?
The steps of the operation are well defined as the mediastinal dissection for transhiatal mobilization of the esophagus begins at the lower end with the hand going up along the prevertebral fascia from above, and then the hand coming down from the neck. And you can't obviously touch those fingers together. So a sponge on a stick, a long sponge carrying on a carrier, going down into the mediastinum along the prevertebral fascia, and then being bounced off the tip of your fingers from below so that you're not going off into space. The sponge stick comes down and it goes into the palm of your hand, and that establishes the posterior mediastinal plane. And once that's done, we pass our long 28 Argyle sump sucker down into the posterior mediastinum to keep things dry, to allow us to see. And once the posterior dissection is done, which is typically a fairly bloodless plane, the anterior dissection begins. It's a mirror image with the fingers of the hand going up along the anterior surface of the esophagus from below and coming down from above through the neck. Again, the fingers typically don't meet. So now we have fingers from below the esophagus here, and you can't get any higher. Now we typically take a sucker, a Yonker sucker, and come down through the neck and put that sucker down along the anterior surface of the fingers, not this way where it'll go into the membranous trachea, but down this way beneath our fingertips between the hand and the esophagus behind it, right into this space, to connect the dots, to connect that plane, so that we then have a communicating tunnel that allows us to put the fingers up and to feel that we have now opened the anterior esophageal plane. So with the anterior esophagus and the posterior esophagus mobilized, we go back to the neck, raise the esophagus, and with that anterior and posterior mobilization, we can deliver more esophagus out of the wound and sweep lateral attachments aside, delivering 5-6 centimeters of esophagus out of the mediastinum. Now, if we drop that back into the wound, then the upper portion of the esophagus, which has now fallen down into the superior chest, has been circumferentially mobilized. So now if the hand goes up into the mediastinum from below until the fingers can trap the esophagus against the prevertebral fascia in that area that has been circumferentially mobilized, the fingers can then come down progressively, and we deliver the vagal trunks, typically on each side, down low enough so that they can be clamped and ligated or divided under vision with a retractor holding the hiatus up and looking up into the hiatus. These lateral attachments can be divided under vision. Clearly, this is where you have to worry about injury to the azygos and so forth, which happens, but not with frequency. But that, in essence, is the stepwise routine that we follow. Posterior mobilization, anterior mobilization, freeing up then the upper portion of the esophagus so that when it drops down, the hand going up can encounter circumferentially mobilized esophagus. The fingers can then be placed
Could
against.
we pull the slides and just flip through those? Because you've nicely described it, and now maybe if we just run through it quickly, I think that would be very descriptive for the audience.
This begins the posterior mobilization from below with the hand from the bottom going behind the esophagus and the hand from above going behind the esophagus from the neck incision. And then here on lateral is that sponge on a stick coming down and meeting the hand coming behind the esophagus. So that's the posterior dissection. The anterior dissection, the mirror image with the hand going up in front of the esophagus and then down from above. And here's the lateral view. And this is where we'll put the suction. The hand will go up as high as we can get it, and the sucker will be used to develop the plane anteriorly. This shows back in the neck, elevating the esophagus out of the neck wound. The patient's head is to the right. And as we draw the esophagus out of the chest, we are sweeping away with this hand lateral attachments. So now with this upper portion of the esophagus mobilized, the hand from below goes up and traps the esophagus against the prevertebral fascia, and the hand is brought down. There's a lateral view.
Very nice.
That's actually very nice. I've never looked at these for a while. And this shows delivering down some of these lateral vagal branches and dividing them under direct vision in the chest. It's seldom necessary. Less than 5% of our patients will require the addition of a partial upper sternal split to mobilize the cervical esophagus. I always ask the residents to evaluate, before the patient's prepped and draped, the distance between the cricoid cartilage and the sternal notch. So in an elderly patient with kyphosis and osteoarthritis and the neck held forward, the cricoid cartilage will rest on the sternal notch. You haven't got a cervical esophagus there. It's behind the sternum, and you can plan that there'll be a cervical incision carried down a little bit onto the sternum through the manubrium for a partial upper sternal split to gain access to the cervical esophagus, which is now up in the superior mediastinum. So the incision would be carried down from the neck and onto the sternum for 5-6 centimeters. And also for the patient who's morbidly obese and has a bull-necked habitus, you may have to do this as well. Now, as you know, if you have a sternal wound problem or an anastomotic leak and you've got a sternum that's been partially divided, you have a complicated wound that has to be cared for. And in our last morbidly obese patients, we've really tried to avoid a sternal split. We've just worked a little harder and pulled the esophagus up into the field so that we could get around the esophagus, and it's been possible in the most. I think the more you do, the less frequently you have to do a sternal split, but it's clearly something you have to keep in your pocket because it's some of these people just don't have a cervical esophagus.
And just a couple questions on this part. Are there any preoperative or intraoperative findings where you would say, we're done with this part, we're not going to proceed? We're either going to bail out or we're going to turn the patient and get a right thoracotomy. For example, a patient with mediastinal radiation from Hodgkin's 20 years earlier, a bulky tumor that might have some concern over a possible T4. You ever not approach it transhiatally because of those preop, or do you think it's worth a try and then you decide that intraop?
We absolutely will approach some directly if there's some pretty hard evidence that we can't get it out. I always say transhiatally, I always say that the most important contraindication to transhiatal esophagectomy is the surgeon's assessment that it's unsafe to proceed. There is no there is no shame in a thoracic surgeon opening the chest. And, but in the patients that I've had with history of mantle radiation in their teens for Hodgkin's disease, and then in their 40s, 50s, and 60s, squamous carcinoma of the esophagus as a complication of radiation, I'm willing to try after chemo and radiation. And often our people will give a second course with that time delay. They'll give a second course of neoadjuvant therapy. I'm willing to try to put my hand up to see if there's a plane. But if there's not, I have a very low tolerance to turning the patient and doing it through the chest and then turning them back. It doesn't happen often, but absolutely you have to be prepared to do that. And the other thing, Jim, that I look for is that on the preoperative CT scan, it gets some red lines on my patient cards before surgery. If the patient has granulomatous disease in their lungs or in the mediastinum and calcified lymph nodes, that's a red flag that the azygos vein may be stuck in the subcarinal area, and you may wind up with a problem with the vein. So it's something to pay attention to when you're doing these resections.
Okay. Achalasia megaesophagus, do you think it's okay to go transhiatally, or is that one you might have a little more concern about?
No, I think it's fine. We have a large series of patients who have had achalasia. There are some real technical nuances when you do the patient with a megaesophagus of achalasia. First of all, that esophagus is typically tortuous and off to the right side, so it's not the typical straight up the mediastinum along the prevertebral fascia. The esophagus doesn't live there, so you have to be prepared to veer over to the patient's right, and often you'll enter the right side of the chest. The muscle of the esophagus is often hypertrophied from years of relative obstruction, and typically the blood supply to that hypertrophied muscle is greater. And when you mobilize the esophagus and get it out, you have to pay particular attention to looking up into the hiatus and visualizing and clamping with these super long right angle clamps and tying vessels in the esophageal bed, or you'll be going back to explore the patient. In the neck, it's a very different operation because the esophagus is dilated all the way up to the neck, and as you go around it with that finger progressively going in front of the esophagus until you get the prevertebral fascia anteriorly and sweep the esophagus over, the esophagus just tends to go forever until you can progressively push it to the left side and get around it. So the dilated cervical esophagus makes the mobilization a little more difficult. Parenthetically, it's why the patients who have achalasia almost never get anastomotic strictures, because you're anastomosing this gigantic esophagus to the stomach up here. And then the final point is that these people with achalasia can get bad dumping symptoms. There's a parasympathetic dystrophy that they have that we've never defined but clearly exists.
All right, can we get to the final step of the operation, the anastomosis? And I know you've changed your technique probably a number of times over the years in terms of your preferred technique. But can you describe briefly your preferred technique currently for the anastomosis in the neck?
The Achilles heel of any esophageal operation becomes that anastomosis. And after we have finished the esophagectomy and mobilizing our conduit and getting ready to bring the two ends together, I'll typically tell my residents, ladies and gentlemen, it all comes down to the next 10 minutes.
And can we pull
We'll bring the pictures back into view, but it comes down to the last 10 minutes, because how that anastomosis is done and whether the patient winds up with a leak or a stricture or both is how the patient's going to eat for the rest of their life. And so all the different nuances of anastomoses, I tried single layer, double layer, interrupted, absorbable suture, running suture, and always wound up with that traditional 12 to 14% leak rate in the neck, which seems to be the standard. And it was the impetus for developing this stapled cervical anastomosis. So remember that I said pink in the belly, pink in the neck when it's time to put them together. So In our first 1,000 of these operations, once we were done mobilizing the stomach, we would pass a Penrose drain, a rubber drain, through the mediastinum, suture it to the gastric fundus, draw the stomach up into the neck, and do the anastomosis. Now, of course, where you put the sutures between the drain and the stomach tip, it was always blue and contused and ecchymotic, but that's how we did it. That's not pink in the belly, pink in the neck. That's pink in the belly, blue in the neck. So we eliminated that. And we don't use bags, and we don't use stitches, and we use a hand. So once the esophagus has been mobilized, this hand from below is pushing the stomach. I'm sorry, once the stomach has been mobilized, that hand is, and the hiatus has been dilated with the arm through there so that we know there's a good opening. We push the stomach up through the posterior mediastinum gently from below until we can feel that stomach through the neck wound from above. A Babcock clamp is used to grab the gastric fundus, not ratcheted down, just to grab it as your two fingers would, and the stomach is pushed into the neck wound by movement from below against the stomach, pushing from below, not dragging up from above, until you have those few centimeters of esophagus into the neck wound. Now the next part of this operation involves placing the stomach back behind the divided end of the cervical esophagus, and now there's a sequential stepwise process that's followed. There are 3 key sutures placed to set this operation up. The one is into the anterior surface of the stomach, down below where the anastomosis is going to go. It's a seromuscular bite, a 3/0 silk into the stomach to draw the stomach up to the surface of the wound. So that shows this traction suture elevating the stomach up to the surface of the wound. The tip of the esophagus is grasped with Alice clamps, and we predict where the anastomosis is going to go. This is an important part of the operation, because if you've drawn the stomach upward into the field and you cut the esophagus too short to make a nice anastomosis, when you let go with that stitch, it all drops down into the mediastinum or into the base of the wound, and there's tension on the anastomosis because you've left the esophagus too short. So you have to bring the esophagus down onto the stomach and predict when this is cut that you'll have enough length to make a comfortable anastomosis. It's not under tension. So a vertical gastrotomy about 1.5 centimeters is made, and the tip of the esophagus, you see here, is being amputated against a vascular forceps that is used to serve as a guide not to crunch the esophagus down. So we have a nice clean margin, and we hold the tip of the esophagus so that one suture is placed at the tip of that divided esophagus, and then the third stitch goes inside the gastrotomy and out, and then outside the back tip of the esophagus and in, and those 3 stitches align the stomach and the esophagus and pull the back wall of the esophagus against the front wall of the stomach. And when that's done, the back of the esophagus, the front of the stomach are together, and allow the insertion of an endo-GIA stapler, which is a 3 centimeter long cartridge, into the wound. And it should be aligned so that the stomach and the esophagus are well aligned, and that the gastric suture line has been rolled over to the patient's right and not included in that anastomosis, or you'll wind up with a major necrosis of the stomach. You must keep that suture line rolled over to the patient's right side. And before we close the stapler, and before firing it, place 2, we call them suspension sutures, because we used to sew the stomach to the prevertebral fascia, which would traumatize the tip and cause ecchymosis that we think hurt healing. We now place 2 seromuscular sutures between esophagus and stomach on either side of the anastomosis, sort of a second row, so to speak, and then we fire the stapler. And when that stapler is removed, the back wall of the esophagus and the front wall of the stomach have been joined, opened, so that you've got a 3-centimeter long anastomosis, a stapled side-to-side anastomosis. And closure then of the remaining esophagus to the stomach is not closing the anastomosis. This is sort of a hood of esophagus that's been laid down over the anastomosis. So what we're closing is just the enterotomies that have been made to do the anastomosis that's underneath this whole thing. And I think that's it doesn't matter how much you turn in, you can really close that off well so that you have this hood of esophagus over the anastomosis. And those are the steps of the anastomosis. We put a nasogastric tube down and mark either side of the anastomosis with a silver clip for future radiographic evaluation so we know where that is. But this is our anastomosis that we've used now for the past 7-8 years, and it's lowered our leak rate to under 3%. It's been a dramatic change, and along with a lowered leak rate comes a lower stricture rate, because I'm convinced that half of the leaks end up with a stricture as healing occurs. So it's really something you have to avoid a leak, and this is what the operation comes down to: a well-constructed anastomosis, no matter where you're doing it.
And then as you're finishing that anastomosis, we've noticed occasionally pull up a little extra stomach. So one of our steps is to gently pull down
Absolutely.
on the conduit until you see this just move, and then we're done. Do you do the same?
Well, obviously, the abdomen's been closed, but as I've said, we know we've pulled stomach up into the neck wound to allow us to do the anastomosis. So a finger just is pushed against the stomach and esophagus, and anastomosis typically drops right into the thoracic inlet, and we lay a drain on top of it. But that is an important step, because you have left it up in the neck wound.
Very good. Well, Dr. Orringer, you've certainly made a very complex operation sound pretty straightforward.
He's just saying that this is not a straightforward operation.
No, but clearly it is a number of steps that you've outlined that take some of the mystery out of this operation, and obviously it's one of the most common operations performed today in the United States and across the world, largely thanks to your experience and your teaching. So thanks for sharing those steps with us today. That's all the questions I have.
Thanks for being here and for doing an interview. It's been a pleasure to be doing this at the AETS meeting for CTSNet.
Thank you.
Pleasure.